Hello, everyone, and welcome to today's edition of Pathcast. Today is October 4th, 2022. And I am Rifat Mannan, joining from California, and I am remotely joined by my good friend and colleague, Emilio Madrigal, who is in Boston. Today, we are very delighted to welcome back Dr. Vijay Joshi to deliver a talk on pediatric pathology, and which is very important for our practice. That is Hirschsprung's disease. And Dr. Joshi is a very well-known pediatric pathologist, as all of you know already. And he is now an affiliate clinical professor at Medical College of Virginia at Richmond. And he would be giving this talk right now. So over to you, Dr. Joshi, and thank you for joining us again. And dear viewers, if you have any questions or comments, you can text on the chat box on YouTube and Facebook, and we will discuss towards the end of the session. So over to you now, Dr. Joshi.
Thank you. Greetings from New Jersey in United States. I thank Dr. Rifat Mannan for inviting me to participate actively in their project of updating topics of practical importance, primarily for pathologists from non-Western countries. Such effort is similar to that of Association of Indian Pathologists from North America, AIPNA. The emphasis of my presentation will be on systematic approach to a routine garden variety case of Hirschsprung disease. But I will also refer briefly to rare variants of Hirschsprung disease and diseases resembling Hirschsprung's disease clinically. In the interest of time, I may not discuss every point on every slide, every text slide. You will have access to my PowerPoint after the presentation, and you can look up the references and other materials. So let's start now. Rifat, I'm not able to change the slide to the next one. Can you do that for me?
Dr. Joshi, you should be able to. Maybe if you, is it not moving?
Oh, now it's moved. Okay, thank you.
Great. Thank you.
Firstly, I thank Professor Raj Kapoor of Seattle, Professor Miguel Raiz Mugica of Pittsburgh, and Professor Usha Kinney of Bangalore, India, for providing articles, slides, and consultation for updating this presentation of mine. Just to briefly introduce you to Hirschsprung's disease, it is seen in neonates primarily in this day and age, but it was also seen in infants and children previously. The main characteristic in the neonate is that there is no meconium passage within 48 hours. In the older children, there is constipation and failure to thrive. Some of the emergency situations in Hirschsprung disease are given on this slide. It may present with features of necrotizing enterocolitis or cecal perforation, particularly in total colonic Hirschsprung disease, which I will come to in my discussion. There is functional obstruction related to defective enteric nervous system, including absence of ganglion cells. That is the basic abnormality in Hirschsprung disease. Definitive diagnosis of Hirschsprung disease can be made only by rectal biopsy, by routine histology, and by ancillary pathology stains for positive features in submucosal neural elements. My emphasis, as I already mentioned to you, is outlining systematic approach to pathologic diagnosis. So this is the plan of my presentation, which will take a broad perspective. Firstly, history, clinical features I have already gone over, pathophysiology, description of negative findings for diagnosis by biopsy, ancillary technique for positive diagnostic finding, systematic approach for examination of biopsy, types of biopsy, problems in diagnosis, extent of involvement of intestine, brief reference to genetics and pathogenesis, diseases resembling Hirschsprung disease, reference to issues in developing countries during discussion of these various points as they come up, and then summary. Historically, it was described in 1886 by Hirschsprung. The main point in the history is that Robertson and Kernohan from Mayo Clinic described the correlation between aganglionosis and intestinal obstruction, and Dr. Swenson from the same institution described rectal biopsy for diagnosis and a corrective surgery. The incidence is worldwide. In fact, it is higher in Asia, as is mentioned here, 1.4 in 5,000 live births. It can be associated with different syndromes, which are mentioned here on the slide. So there is non-syndromatic and syndromatic type of Hirschsprung's disease. There are about 700 cases of Hirschsprung disease per year in the United States. There is global prevalence of Hirschsprung disease, as I already indicated. The pathophysiology relates to functional obstruction in Hirschsprung disease. Muscle contraction and relaxation are controlled by neurons of entering nervous system. Cholinergic nerve fibers in the intestine cause a contraction, and adrenergic fibers cause inhibition of contraction, that is relaxation. There is increased cholinergic activity in Hirschsprung disease as compared with adrenergic activity. And that results in increased muscle tone in the involved segment, which leads to functional obstruction. That is pathophysiology very briefly described. Now let's move on to the most important aspect of this presentation, and that is systematic approach to pathologic diagnosis. And I will describe the crucial role of pathologists in this diagnosis. So there are 6 basic aspects of biopsy in Hirschsprung disease. Number 1, the site is a very important one. It should be 2 to 3 centimeters above pectinate line to avoid normal hypoganglionic anal zone extending 1.8 centimeters proximal to the line. This site should be confirmed with pediatric surgeon. They know the basis, they know the requirement, so it is always done that way, but it is better to confirm it. And they should mention the site, the distance on the surgical pathology requisition form. The pectinate line is between the columnar epithelial lining of the anal canal and the junction between and its junction with the squamous epithelial lining of the anal canal. There are usually 2 pieces taken for biopsy, one from each of 2 different sites. This is a photomicrograph to show you the epithelial junction, the squamous epithelium and the columnar epithelium at the pectinate line. And this is a diagrammatic representation to show the pectinate line and the biopsies, and the zone shown between the biopsy site and the pectinate line is the hypoganglionic zone. Actually, it's 1.8 centimeters, but to be safe, it is recommended that the biopsy should be taken proximal to 2 to 3 centimeters, that is 2 to 3 centimeters from the pectinate line. In the normal hypoganglionic anal zone, there is hypoganglionosis or absence of ganglion cells and presence of prominent nerves as is shown here. So you are seeing here prominent nerve and you are seeing a ganglion cell. This type of combination is seen in normal hypoganglionic anal zone. There are 2 types of biopsies that you will get. Full thickness rectal biopsy, which shows both myenteric and submucosal plexuses. This is not done anymore, and I'll come to that point as we go on. The biopsy that you are going to receive will be submucosal suction rectal biopsy, 2 to 3 centimeters from the pectinate line. In this biopsy, only submucosal plexuses are present. Judging the distance accurately from the pectinate line can be difficult because there is the patient is not under anesthesia. And another disadvantage of this submucosal suction biopsy is that you may have to deal with immature ganglion cells in the submucosal plexus in neonates. So, firstly, the full thickness biopsy. The full thickness biopsy is a larger biopsy. It shows both myenteric and submucosal plexuses. Myenteric plexuses show more mature and more numerous and larger ganglion cells, but this requires general anesthesia. The distance can be accurately judged. There may be some complications associated with it. So for all these reasons now, there is discontinuation of full thickness biopsy, and what we get essentially are suction biopsies. No anesthesia is required. Distance may be difficult to judge. These biopsies are smaller. The ganglion cells are less numerous and less mature, but multiple samples can be given to us and the complications are minimal. The only disadvantage is the small size of the biopsy, but with experience, we can learn to live with the small size. This is an example of submucosal biopsy in which you are seeing immature ganglion cells, which may be difficult to recognize. But I will come to this point as we go on further when I deal with problems in diagnosis. Now, as far as this number of samples is concerned, there is variation in practice. The best one that I have seen in my own experience is that you get 2 samples from each of 2 sides, 3 and 4 centimeters from the pectinate line. The next important point is the orientation of the biopsy, and this is something I have, in my experience, developed an understanding with the pediatric surgeon who train their nurses in the OR to flatten the biopsy on the filter paper where it tends to curl up, and therefore flattening it on the filter paper is very important. And the next step, which is important, is immediate adequate fixation of the biopsy of the larger piece in the of the 2 pieces after arrival in the lab, and there should be immediate transport to the lab. All these things should be worked out with the pediatric surgeon ahead of time for every biopsy, and once the understanding is developed, this will automatically occur in every case. Now, the next step in the biopsy is thorough examination of 40 to 60 sections. You can easily accommodate 40 to 60 sections by putting ribbons on slides, and all that you need is 3 to 4 slides. And I'll come to this point again when I talk about resources in developing countries. And this is required to demonstrate absence of ganglion cells. So to emphasize the steps in the biopsies: flattening on the filter paper, immediate fixation. I said by the surgeon, that is not advisable really, because he may not know exactly which piece to put in the fixative and which piece to keep in maintain in saline for frozen section for acetylcholinesterase. So what I've written on this slide is something that should not be followed. It should be the flattening on the filter paper only in the OR and immediate fixation by the pathologist and flattening of the biopsy in the surgical pathology lab. Now, one of the samples is taken for frozen section for acetylcholinesterase. What we do is we put the larger piece in the smallest mold and trim the face of the block. And then we can easily mount 15 to 20 sections on a single slide, and we need only 3 to 4 slides for 40 to 60 sections. Ganglion cells, when present, are seen in the first 15 to 20 sections usually. Some pathologists advise 60 to 80 sections for diagnosis of Hirschsprung disease. I have followed the practice of 40 to 60 sections, and that has proved to be adequate in my experience. This is to show the the most smallest mold, and this is to show the trimming of the biopsy. So you have only small amount of paraffin around the biopsy sample, and then you can have multiple sections, ribbons, actually multiple ribbons on a single slide, and you can have 15 to 20 sections on a single slide, so that you can have 40 to 60 sections between 3 and 4 slides. Now, when you are reviewing the slides, you have to concentrate on the differences between the basic structure of plexuses seen normally and nerves seen in Hirschsprung disease. So when you have a normal plexus, you see ganglion cells and glial cells with oval to round nuclei. You don't see Schwann cells in normal plexuses. You see glial cells with oval to round nuclei. They are the plexus presents a loose vacuolated structure, and the oval nuclei are randomly arranged, and there is no collagen. There is no parallel arrangement of these oval to round glial cells. So this is a photomicrograph to show you the ganglion cells, the vacuolated appearance, the loose vacuolated appearance of the normal plexus, and the small round to oval cells which are randomly arranged in the plexus, not in the parallel manner. In a given section, you may not see all the features of the ganglion cells. Here, the nucleolus is just becoming visible. Here, the large nucleus is seen, but the large cytoplasm is just becoming visible, and the nucleolus is not seen. Here, you are seeing the nucleolus, but the large cytoplasm is not seen, and here you are seeing something in between. So please keep in mind that in every section you will not see all the features of the ganglion cells, but you will see all the features when you review multiple sections. So in contrast to the normal ganglion, I'll come to what you see in the nerve in the Hirschsprung disease. But before I do that, I just want to mention to you that the number of ganglion cells in a normal plexus is variable. It can vary from 1 to 10 in mesenteric plexus. We don't have to deal with that for diagnostic biopsies, but for submucosal plexuses, they can vary from 1 to 5, and mostly the submucosal plexuses contain 1 to 2 ganglion cells, although occasionally you may have as many as 10. This is an example of a submucosal plexus to show the variable number of ganglion cells. When you are examining a case of Hirschsprung disease, you will not see ganglion cells, you will not see the normal plexus, but you will see compact structures with parallel arrangement of neurites and accompanying Schwann cells, and collagen is present. That is, you are seeing prominent nerves and not plexuses in Hirschsprung disease. And this is the structure you will see instead of the ganglion. This is a nerve with parallel arrangement of the elongated Schwann cells, and there are no ganglion cells. And there is a kind of wavy outline to this structure. And this is a higher power view of the same to show you the parallel arrangement of spindle cells of Schwann cells, no ganglion cells. For the uninitiated, I'm showing you this slide because hypertrophic or hyperplastic smooth muscle of the submucosal vessels or of the muscularis mucosae may have some resemblance to hypertrophic nerves in Hirschsprung disease, but the staining quality is different, and with experience you can readily distinguish between these and the prominent nerves of Hirschsprung disease. Now, you have a normal hypoganglionic anal zone, which I have mentioned. That and the transition zone between the aganglionic segment of Hirschsprung disease and the proximal normal ganglionic segment show nerve-like structures with rare ganglion cells. So that is what you might see if the biopsy is too low and not from the recommended site of 2 to 3 centimeters from the pectinate line, or you will see these features in the transition zone. That is, a prominent nerve-like structure, and very few or no ganglion cells. This is quite different than from what you see in Hirschsprung disease. So the basic abnormality in Hirschsprung disease is absence of ganglion cells and presence of nerves, as I've already shown you. Now, absence of ganglion cells should be easily recognizable when the biopsy is adequately fixed. But if the fixation is delayed, which might happen on some occasions, which should be avoided, degenerative changes or autolytic changes can occur in ganglion cells, and you might see a picture like this, and you might wonder, am I seeing a ganglion cell, or am I seeing something else? But with experience, you will learn to recognize this, and this should be avoided in the first place, this type of change in the ganglion cells. Now, we have so far talked about the biopsy examination for H&E staining. Now, let's move on to the fifth step, and that is the biopsy studies for ancillary stain. And for this particular purpose, the smaller of the two pieces should be used for frozen section for acetylcholinesterase. And if you don't have facilities for the stain in your own lab, you will have to send it overnight to the referral lab. Now, there are new emerging alternatives. This is the sixth aspect, important aspect of the biopsy, that is new emerging alternatives for diagnosis using permanent sections instead of frozen section for positive finding, that is choline transporter, and substantiating negative finding, calretinine. So we will come to this as we go on. So just to emphasize the important aspects of processing of the biopsy, you need to show absence by systematic, thorough examination of well-oriented, adequately fixed biopsy from proper site. And you have to keep in your mind the possibility of having biopsy coming from hypoganglionic anal zone, which I mentioned to you. Now, Hirschsprung disease is characterized by aganglionosis. Hypoganglionosis was considered as an ill-defined and controversial entity, my experience, but now in recent years, definitive articles have appeared on congenital myenteric hypoganglionosis, and I will come to that as we go on in the latter part of our discussion. This is the picture I have already shown you in Hirschsprung disease, hypertrophic and hyperplastic nerves and not plexuses in the submucosa. Now, the next step, the first step, as I mentioned to you, is to demonstrate the absence of ganglion cells, which is a negative finding. Now, I personally like to substantiate a negative finding by a positive feature. And for that reason, acetylcholinesterase stain is used on frozen section of a biopsy specimen, because there is increased cholinergic activity in a ganglionic segment. This was described a long time ago, but a definitive article appeared in 1974, and acetylcholinesterase staining fibers are absent, or minimal small amount of fibers are present in the mucosa and muscularis mucosae in a normal infant. And in an abnormal infant with Hirschsprung disease, you see the fibers in the muscularis mucosae and later in the lamina propria. This is an example of positive and negative staining, which I have been given by the courtesy of Professor Rais Mucosa, Rais Mugica, I'm sorry. This is the positive staining of the acetylcholinesterase in the muscularis mucosae. Only a few fibers are seen in the lamina propria. This is described as the neonatal pattern, and this is completely negative result in a normal infant. This is the positive result in a Hirschsprung disease. So see how clear it is to make a diagnosis. This is a high power view of the normal infant to show the negative finding, and this is the high power view of the infant with Hirschsprung disease to show you the positive finding, fibers mainly in the muscularis mucosae with only a few fibers in the lamina propria. This type of finding, the neonatal pattern of positive staining, may be considered as negative by some uninitiated pathologists, but you have to remember that this is the neonatal pattern. The extension of the acetylcholinesterase fibers into the muscularis mucosae occurs after 6 months of life. Doing this stain is no big deal. You can readily train a histotechnologist in your lab, and I have done this in my own labs when I was in active practice. I have mentioned S100 here because I mentioned Schwann cells in the nerves. The Schwann cells do stain positively in the nerves in the submucosa in Hirschsprung disease, but you cannot demonstrate the fibers, the acetylcholinesterase fibers in the muscularis mucosae or the lamina propria by S100 stain. So this is the neonatal pattern to show the acetylcholinesterase fiber primarily in the muscularis mucosae, and this is the infantile pattern, so to speak, in which there is marked extension of these fibers into the lamina propria of the mucosa. And this is just a higher power view to show you that there is more extensive extension. Now, this is a S100 stain. You cannot see the cholinergic fibers in the submucosa in the muscularis mucosae or the lamina propria by this S100 stain. That's why we don't do it. Now, since we have one negative finding, there is another negative finding which has been described in the literature, and that is another negative finding. And so some pathologists would be satisfied with two negative findings rather than with having just one negative finding. And this can be done. The advantage of this stain calretinine is that you can do it on permanent sections. And this is an example of calretinine. Calretinine is positive in the normal infant, as is shown here. This also I have received by courtesy of Professor Rais Mugica. And this is high power view of the normal. It is punctate staining. You don't see fibers as in acetylcholinesterase stain. This is punctate staining. And this is another view to show you the punctate staining in the muscularis mucosae. In Hirschsprung disease, calretinine is negative. So this is another negative finding, in addition to absence of ganglion cells. So this is negative, no granular staining or punctate staining in Hirschsprung disease. And this is the higher power view to show the similar negative staining in the muscularis mucosae. Now, so what you have with calretinine is that you have two negative findings. That is absence of ganglion cells and absence of calretinine staining. And this, to the way of thinking of many pathologists, is sufficient for definitive diagnosis. So the advantage of calretinine is that there is no need for frozen section. And as I already mentioned, this ancillary method substantiates or gives you two negative findings to substantiate one negative finding, that is absence of ganglion cells. So what we can do is examine one slide. We need not have 20 to 40 or 40 to 60 sections for calretinine staining. We can have just one slide with a ribbon or even not 2 or 3 sections and demonstrate the negative, the absence of calretinine staining in Hirschsprung disease. This has been considered as a reasonable and potentially superior alternative of practical importance to acetylcholinesterase by many experts in Hirschsprung disease. But now another ancillary technique has been described by Dr. Kapoor, and that is a positive finding. That is the advantage. So now you have two positive findings, acetylcholinesterase and choline transporter. The advantage of choline transporter is that you can use it on paraffin section. So you don't need a frozen section. That is a great advantage. So this is the negative staining of choline transporter in a normal infant, and this is the positive staining, marked positive staining, just as good as acetylcholinesterase. And the staining is in the muscularis mucosae and to some extent in the lamina propria. So this is choline transporter on paraffin sections, which is positive in Hirschsprung disease. There are advantages that it is a positive result. Frozen section is not needed, and now the antibody is commercially available, so you can use it in your laboratory. The one sort of disadvantage, so to speak, of choline transporter is that it may not give strong positive staining consistently in Hirschsprung disease. And this is an example of a weaker staining in one of the cases that were sent to me. And this is an example of weaker staining on choline transporter. This is still positive. This is recognizable. And on the basis of this and the absence of ganglion cells, we can definitely diagnose Hirschsprung disease. And this is just to compare that weaker staining with a very strong staining. Now, in Hirschsprung disease, again, another point about the ganglion cells I wanted to make was the absence of ganglion cells, that you may not see all the features of ganglion cells in all the sections of a normal plexus. Now, this brings me to adequacy of biopsy in Hirschsprung disease. Adequate suction biopsy, it is stated in the literature, contains sufficient submucosa to exclude submucosal ganglion cells with thorough histological examination. Now, the question is, how much is sufficient? I have used a personal guideline, which is given on this slide. Submucosa of same thickness as mucosa should be present in the suction biopsy. But this is not good enough. The real criterion that I have used for sufficiency or adequacy is that there should be at least 3 to 5 neural elements seen in multiple sections for evaluation. And multiple, I mean 5 to 10 sections, because this is what I have used as a guideline for the submucosal, for the adequacy of submucosal suction biopsy. Now, you may be dealing with practical issues like this. You have a submucosal biopsy. It is adequate. The submucosa is of adequate thickness, far more than the mucosa, but there is a large hemorrhage. So you wonder whether it is adequate for examination. But when you look at the hemorrhagic area, you can readily see the hypertrophic prominent nerves and not plexuses in this hemorrhage. So despite hemorrhage, it is adequate. Now, this is another example to show you the adequacy of the biopsy in terms of thickness and also in terms of presence of prominent nerves in the submucosa, as you can see here. This is another example of a biopsy in which in one part only mucosa is seen, but in the deeper sections, you could see the submucosa, but it is of a very small thickness, less than half of the mucosal thickness. But you can still see a prominent nerve in this small amount of submucosa. And on higher power, you can readily recognize that as a prominent nerve. And as long as this type of structure is present in 3 to 5 sections, different sections, and you can see this in 5 to 10 different levels, that is adequate. So the adequacy is not related to the thickness of submucosa, but to the number of neural elements in the biopsy specimen. But if with all your effort, if you think that the biopsy is inadequate, I would advise that put in maximum effort to establish or rule out the diagnosis of Hirschsprung disease by cutting through the entire block. And so this will possibly give you the diagnostic features in the biopsy, and you will be able to avoid the pain and inconvenience of repeat biopsy in a neonate or infant, in a child and the parents. Now, with this, now we come to the problems in diagnosis. Firstly, in newborn infant. Now, I have said more than 70%. This is an old slide. Now, more than 90% of the cases in Western part of the world are diagnosed in Hirschsprung disease, are diagnosed in the newborn. And one issue is the immaturity of ganglion cells. NSC stain might be helpful in this regard, but I have hardly ever used it, because once you learn to recognize the ganglion cells, you are pretty good at it. This is an example of an immature ganglion cell in an immature plexus in a newborn. And this is a high power view to show you the immature ganglion cells. The immature ganglion cell here is not very well marked, but here you can see the immature ganglion cell. In deeper sections, you will be able to see better features. Here is another immature ganglion cell. So you may want to do an NSC stain, but I have not used it, but you may want to do it. So recognition of ganglion cells in the newborn infant may have this difficulty of immaturity of ganglion cells. Another problem is in the diagnosis is regarding ultra short segment of Hirschsprung disease. I will come to this discussion with the extent of involvement of intestinal tract in Hirschsprung disease. So let's move on to another problem, and that is the problem of making a definitive diagnosis or a primary diagnosis on a frozen section. And that situation may present to you when there is emergency surgery required for necrotizing enterocolitis of proximal colon or cecal perforation in a suspected case of Hirschsprung disease, or there may be need for emergency colostomy in a suspected case of Hirschsprung disease. So in that situation, you may be called upon to make a primary diagnosis of Hirschsprung disease on frozen section. Presence or absence of overall structural and cellular features of normal nerve plexuses can be appreciated in frozen section, but multiple frozen sections of the block are needed for definitive demonstration of absence of ganglion cells. This is a practical situation which is rarely needed, but you have to be familiar with this. So recognition of ganglion cells in frozen section is neonate is maybe even more difficult because of immaturity of ganglion cells. So with this situation, you request the pediatric surgeon to give another piece from the same side, and you process that second piece for permanent sections to confirm your diagnosis made on frozen section. It has been, I have personally said that frozen section should not be used for primary diagnosis of Hirschsprung disease, except in situations of emergency surgery. And this has been shown by a study reported in American Journal of Surgical Path, which is given here on this slide. And that is no ganglion cells on frozen section. There were concurrence was seen only in 89% of the cases, whereas concurrence between diagnosis of frozen section and permanent section was seen in as many as 99% of the cases in other surgical path cases. So the conclusion is that frozen section should not be used for definitive primary diagnosis of Hirschsprung disease. But in a developing country, there may be a situation where a patient may not return for definitive diagnosis, for definitive therapy after study of permanent sections and the final report coming out the next day. So in that situation, an intraoperative diagnosis may be needed on frozen section on which acetylcholinesterase stain can be done. And this technique, a modified rapid staining method, has been developed by Professor Usha Kinney of Bangalore in India. She has established a referral center in her medical school, and she gives hands-on workshop every year for pediatric surgeons and pediatric pathologists regarding this technique. Now, I have mentioned to you what are the problems in the diagnosis. Now let's move on to the extent of involvement of intestine in Hirschsprung disease. The most common is the short segment Hirschsprung disease, in which sigmoid and colon and proximal rectum are involved. And then there are uncommon or rare variants of Hirschsprung disease, total colonic Hirschsprung disease, ultra short segment Hirschsprung disease, entire involvement of entire small and large intestine, and then zonal Hirschsprung disease with skip areas. So the most common is the short segment. In that type of Hirschsprung disease, you have a narrow portion, you have a dilated portion, and you have a transitional zone. In narrow portion, no ganglion cells and only hyperplastic nerves. In dilated portion, normal plexuses with ganglion cells. And in transitional zone, normal plexuses and nerves with or without ganglion cells. So this is the mixed picture in transition zone. This is a characteristic gross photograph of specimen. The narrow aganglionic zone, the dilated normal ganglionic zone, and the transition zone. And this is a diagrammatic representation of distal narrow aganglionic segment, the proximal normal ganglionic segment, and the transitional zone. So in the narrow segment, no ganglion cells, only prominent nerves. And in the transition zone, an admixture of prominent nerves and some plexuses, and even some of the nerves will show ganglion cells. So this is the mixed picture in the transition zone, same type of picture as seen in the hypoganglionic anal zone. And this is the picture in the normal zone, that is the dilated ganglionic zone, in which you see normal plexuses. The second type, the rarer type variant of Hirschsprung disease, is the total colonic involvement. And this is a photomicrograph. This is a gross photograph of resected specimen, in which you see the appendix, you see the ileum, you see a portion of terminal ileum here, and you see the colon. The entire colon is narrow or collapsed. There is no dilated segment. The dilated segment is only in the ileum. So this is total colonic involvement. When you see a rectal biopsy from a patient with total colonic involvement, you see the norm findings of usual Hirschsprung disease, and that is the prominent nerves in the submucosa and no ganglion cells. However, when you look at the involved colon, you see total absence of neural elements in the submucosa or in the muscle coat. Total absence of neural elements. There are no plexuses, there are no nerves, no neural elements. This is the picture that you see in total colonic Hirschsprung disease. In the rectal biopsy, there are prominent nerves, but in the colon, in the involved colon, there are no neural elements. So to get a properly oriented section in the operating room, it may be difficult to make sure that you have both the layers of muscle coat to look for the myenteric plexus. And therefore, I request the pediatric surgeons to give me the entire appendix. This is a standard practice, so that you have a much larger specimen and you can have a much better orientation of the specimen, and you can look at the both the layers of muscle coat, and you can see the absence of any neural elements in the submucosa and in the muscle coat. So this is what you see in the rare variant of total colonic involvement. Now let's move on to the another rare variant, that is the ultra short segment Hirschsprung disease. This is a rare, controversial, and variably defined variant manifesting in an older child. There is involvement of only less than 1 to 2 centimeters of distal rectum. although according to some authors, even 3 to 4 centimeters of the rectal segment may be involved. But most authors consider less than 1 to 2 centimeters as indicative of ultra-short segment Hirschsprung disease. In view of very short length of involved segment, you need a low rectal biopsy to demonstrate absence of the absence of ganglion cells, and you need acetylcholinesterase stain for the definitive diagnosis. Because if you have the biopsy from the usual recommended site of 3 to 4 centimeters from the pectinate line, you will see ganglion cells, because this is an ultra short segment Hirschsprung disease, and therefore you need a biopsy from a lower site. Now, the involvement of entire GI tract is extremely rare, and this is incompatible with life. Now, hypoganglionosis. I mentioned that hypoganglionosis was considered as controversial, but now this is a recently characterized rare entity. It is called congenital myenteric hypoganglionosis. So there is severe persistent intestinal dysmotility in neonates and infants, and suction rectal biopsy is negative for Hirschsprung disease. That is, there are ganglion cells present. The findings are of congenital myenteric hypoganglionosis are present in the full thickness biopsy or resection. In the submucosa, you have neural plexuses and no significant nerve hypertrophy. The diagnostic findings are present only in the myenteric plexuses, and these consist of immaturity of ganglion cells, reduced number of ganglion cells to about 3 per millimeter of the plexus of the nerve or the plexus. Normally, there are about 15 ganglion cells per millimeter of plexus in the myenteric plexus, and there is reduced size of ganglion cells. There is weak calretinine staining. Strong staining is present in normal, and negative staining is present in Hirschsprung disease. But diagnosis can be, it is said in the definitive article on this subject that diagnosis can be made in moderate to severe cases without actual counting. So this is a new entity which you may encounter. There is a persistent dysmobility after ileostomy, and the overall outcome is poor. There is no direct causative relationship to Hirschsprung disease of this particular entity. There are other isolated reports of congenital myenteric hypoganglionosis and even acquired myenteric hypoganglionosis in the literature. Now, this slide is a repeat slide. Now let's move on to diseases resembling, clinically resembling Hirschsprung disease. Intestinal neuronal dysplasia, intestinal ganglionuromatosis or neurofibroma, and chronic intestinal pseudo-obstruction of two types: myopathic, in which there is vacuolar degeneration and fibrosis of muscle coat on trichrome stain, and neuropathic subtype, in which there is degeneration of neurons, eosinophilic inclusions in the neurons, and Schwann cell proliferation. This is extremely rare. I have not seen a case of this, so I cannot demonstrate to you. You have to look up the literature for this if you come across a case. But the findings are described in two subtypes, that's myopathic and neuropathic. Now, the next one is the intestinal neuronal dysplasia, and that is a controversial entity. There are two types described, type B and type A. In type B, the criteria are given as follows: that is, more than 20% of submucosal plexuses with 9 or more ganglion cells, and you should evaluate 25 plexuses to make the diagnosis. This is intestinal neuronal dysplasia type B. Now, the diagnosis of intestinal neuronal dysplasia is controversial in type B. So what we have now come to consider type B is actually type. So, in intestinal neuronal dysplasia, which was described as uh, type A, is now considered as type B actually, and even type B is considered with healthy skepticism. This is an example of a case that I had come close to making diagnosis of intestinal neuronal dysplasia, in which you can see as many as 20 ganglion cells in this plexus. The next category to describe is intestinal ganglionuromatosis. In this, there is intestinal obstruction, GI bleeding, and abdominal pain, and there is hematomatous proliferation of ganglion cells, nerve fibers, and Schwann cells. And this is intestinal ganglionuromatosis with clinical features resembling Hirschsprung's disease. And this is a high power view to show you the proliferation of ganglion cells and Schwann cells and nerve fibers in intestinal ganglionuromatosis. Now, the pathogenesis of Hirschsprung disease is important. There are main features to be considered in pathogenesis are absence of ganglion cells, hypertrophic nerves, and defective GI motility. Now, the genetics of Hirschsprung disease is complex and is incompletely understood. Several mutations of several genes have been described, and the mutation of these genes explains the defective migration, replication, differentiation, and survival of neural crest cells, which give rise to ganglion cells. And therefore, there is absence of ganglion cells because of mutation of these genes. There is experimental evidence in mice that vitamin A depletion may also interfere with the maturation and survival and replication of ganglion cells. And this is particularly of significance. This observation is particularly of significance in developing countries, because we might wonder whether the prevention of some cases of Hirschsprung disease is possible in developing countries by optimizing maternal nutrition. Now, the next aspect in pathology of Hirschsprung disease is the presence of hypertrophic nerves. There is no good explanation for that, but it has been suggested that there is increased number of mast cells in the involved segment, and this may be related to hypertrophic nerves. The defective GI motility may be related, in addition to the abnormalities of enteric neural plexus, it may be related to reduced number of interstitial Cajal cells. Interstitial Cajal cells and their network is essential for GI motility coordination. So these are the various factors in pathogenesis of Hirschsprung disease. There are rare cases of so-called acquired Hirschsprung disease, and this can occur following necrotizing enterocolitis, in which there will be necrosis of ganglion cells in the involved segment, and this will lead to a clinical picture resembling Hirschsprung disease. In Chagas disease, that is trypanosomiasis, involvement of enteric neurons can occur, and this can lead to clinical features resembling Hirschsprung disease. And in Chagas disease, there are actually ganglionitis with depletion of ganglion cells. Ganglionitis, enteric ganglionitis, has also been described in rare instances in which there is infiltration of the ganglion of the plexuses by T cells, by T lymphocytes. It is an extremely rare entity. Another type of acquired Hirschsprung disease can occur after definitive surgery in children with Hirschsprung disease. Despite definitive surgery, the patient continues to have obstructive symptoms. A submucosal biopsy will show absence of ganglion cells, presence of prominent nerves, and subendothelial and medial fibrosis of blood vessels. This has been attributed to regional ischemia of pull-through bowel causing aganglionosis. So this is a rare situation of so-called acquired Hirschsprung disease. Hirschsprung disease can also occur in adults. Chronic constipation, abdominal distension may be present in such patients. Hirschsprung disease may remain undiagnosed in adult age for various reasons. 490 cases have been reviewed in a recent in an article published in 2010. Histological confirmation can be made on a rectal biopsy. This is the specimen of adult Hirschsprung disease that I saw in the Virchow Museum in Berlin, in the Department of Pathology where Rudolf Virchow worked. This is an interesting specimen. Now, just to summarize, the crucial role of pathologists in diagnosis of biopsy, there are basic aspects like biopsy site, ascertain that it is proximal to normal hypoganglionic zone, thorough examination of 40 to 60 sections is required. There are differences between basic structure of the normal plexus and a nerve in Hirschsprung disease, and I have already illustrated these to you. The vacuolated loose appearance of plexus with ganglion cells and glial cells, and a compact wavy structure of a hypertrophic nerve in Hirschsprung disease with Schwann cells and no ganglion cells. Frozen section for acetylcholine stain to demonstrate a positive finding is an important aspect of diagnosis. In my experience, although calretinine, a negative stain, may be used by some pathologists, and choline transporter is now coming in the picture as a positive finding. So this is the picture of acetylcholinesterase, positive in Hirschsprung disease, negative in normal infant. Now the gold standard is absence of ganglion cells and presence of hyperplastic nerves, reviewed after demonstrated after review of 40 to 60 sections in 4 to 5 slides. Having 40 to 60 sections on 4 to 5 slides, I don't think is a strain on resources in resource-restrained laboratories in developing countries. Some pathologists have lowered the threshold for submucosal sampling because now they routinely use calretinine stain, and they may use only 10 to 20 sections for of H&E stain for histologic examination. But my personal choice and recommendation remains that you should review 40 to 60 slides. And the current trend is to diagnose Hirschsprung disease by 2 negative results, that is absence of ganglion cells and absence of calretinine staining on immunohistology on paraffin sections, and this is considered as sufficient for diagnosis. I, in my own experience and in my own thinking, will need a positive feature in addition to a negative one for diagnosis, and therefore acetylcholinesterase stain or choline transporter stain should be used for positive staining. There are some issues with choline transporter staining, and therefore I would recommend continued use of acetylcholinesterase stain for positive finding. Thank you for your attention, and if you have any questions, you may ask at this time. Thank you. There are no participants?
Thank you so much, Dr. Joshi. No, there are participants, definitely. So the participants are online on Facebook and YouTube. So that's why you are not seeing them.
So should I stop share? Should I click on stop share?
Yes, yes. Yes.
And click on start video?
Yes, you can do that. Yeah, there are a few questions, Dr. Joshi.
Okay.
One question that I can see here is about calretinine. That is calretinine a very specific stain for ganglion cells and nerve fibers?
Well, it is in a way, not for ganglion. I would say it is for nerve fibers of a particular type, and it is very useful. The only thing that I have reservation with calretinine I have is that it is a negative stain, and it is another negative finding. So you have 2 negative findings: absence of ganglion cells and absence of calretinine staining. So on that basis, many pathologists can confidently diagnose Hirschsprung disease.
Right. So, I mean, in practice, do you consider or do you suggest using L-retinine to our colleagues for diagnosing Hirschsprung?
Well, it has choline transporter may not be as widely available as calretinine, and choline transporter itself may have still issues of having very strong staining. So in that situation, as a practical guideline, I would recommend calretinine. Yes.
Right. Thank you. There is another question. So if clinically a child is suspected to have Hirschsprung disease, and histologically we see maybe just one ganglion cell, so do we have a diagnosis of hypoganglionosis? So what's your suggestion?
No, I have said, I have said many times that one ganglion cell and you rule out Hirschsprung disease. The thing is that you have to verify the site of the biopsy. Make sure that it is not from hypoganglionic zone, or it is not too high, in the sense it is not from transition zone. Because in normal hypoganglionic anal zone and the transition zone, you might see combination of finding, which might confuse you. So total absence of ganglion cells by thorough examination is required. Now, hypoganglionosis, I mentioned that in the past, it was considered as a controversial entity. There is no hypoganglionosis of submucosal plexus. There is hypoganglionosis only of myenteric plexuses. So on the submucosal biopsy, which you are going to see in a case of Hirschsprung disease, you are not likely to see hypoganglionosis unless your biopsy comes from a wrong site, as I mentioned. All right.
Right. No, thank you again, Dr. Joshi.
Yeah.
So here is another question that I can see. How do I recognize simply the ganglion cells? Could you please give me some tips?
Singly? Is that what he's saying?
Simply, just
simply.
The tips to recognize ganglion cells on H&E.
Okay, I have illustrated that to you. See, it is a much larger cell. It is a pyramidal. It has a pyramidal shape. It has a large amount of cytoplasm. It has a large nucleus. The nucleus has a nucleolus. Now, all these features I have emphasized may not be seen in every section. And I illustrated. Can I go back to that particular photomicrograph?
Yeah, you will have to share the screen again, Dr. Joshi.
Oh, I see. Okay, let me go back to that and then talk on that basis.
Yeah, I can see your screen.
Now, let me see. Let me go to that particular slide. It illustrates, this slide here.
Yes.
It's not showing up. Is it showing you?
Oh, no, it's dark.
So shall I say stop share? No. Okay, let me go back.
No, it will come back. It will come back. I think some.
All right. Oh, here it is. Okay, yes. I'll just stick with the. Oh, let me go back to that slide, and these two slides, one after another, will be able to answer the question that he has posed. Okay, this one here. No, one more. Sorry, I have to go further up. Where is it? Yeah, here it is. This one first. This is ideal. It is a large cell. It is pyramidal in shape. It has a large nucleus, abundant amount of cytoplasm. It has a prominent nucleolus. Another one here. You will have no problem in recognizing this. But if you have something like this, for example, this one here, there is a shadow-like outline of a large cell. There is a nucleus which is not clearly seen. The nucleolus is absent. Here is another cell which is not as big as the previous one. It has cytoplasm, it has a large nucleus, and it has a rather unclearly seen nucleolus. And so these two cells, and this is another cell here, which may or may not be ganglion cell. But if you see something like this, these two cells, you have to look at the next level. I mean, you have to look at multiple levels to be absolutely confident. But in addition to that, concentrate on the general structure of the neural element. It is oval in outline. It has a vacuolated, loose appearance. There are round or oval cells, nuclei of glial cells. There are no Schwann cells. There are no Schwann cells. So overall structure of the neural element that you are looking at in your biopsy will tell you whether you are looking at a plexus or whether you are looking at a nerve. And the nerve has a much more compact structure, a wavy outline. It is not vacuolated. So the difference between the general structure, general pattern, general architecture of the normal plexus versus the prominent hypertrophic nerve in Hirschsprung disease, it's quite marked, and that you should use in addition to identification of ganglion cells. And if you are not confident about this particular cell being a ganglion cell, then I would recommend, as I said, go to the next level. And that is the importance of examining multiple levels, 40 to 60 levels of the biopsy. I hope you got something out of this long-winded answer. Thank you.
No, that's excellent, Dr. Joshi, because sometimes these small things are not discussed, which is very important. To someone who is new and learning to recognize a ganglion cell versus nerve fiber. This is very helpful. Thank you, Dr. Joshi.
No, well, Rifat, I might emphasize again that the point I made about the general architecture of a plexus versus the general architecture of the nerve in Hirschsprung disease is not emphasized in the literature. Right. Even in my own writings, I have not emphasized that. Although in my presentations, I emphasize it. And I have said several times, and I have myself experienced in my own practice, that you start looking at a slide and you see a structure like this. Right. But there are no ganglion cells, not even these kinds of cells, because in submucosal plexus, there may be only 1 or 2 ganglion cells, and in a given level, you may not see a ganglion cell. But if you see this architecture, you say to yourself, this resembles a normal plexus. Now I have to go to next level, to further levels to demonstrate a ganglion cell in it. A nerve is completely different. So I think if you keep this in your mind, you should not have a problem in making a diagnosis or ruling out a diagnosis of Hirschsprung disease. Okay.
I think this is the most important teaching point, because like most of the time we will be struggling to confidently recognize the ganglion cell on the H&E sections. I think this is very helpful. Thank you, Dr. Joshi. So there is another question from another viewer, that when we use calretinine, how many slides do we stain with?
Yeah, this is something I have, I think, said in my presentation, that for H&E, you have to have 3 to 4 slides with 40 to 60 sections. For calretinine, you don't need that. For calretinine, I would suggest you may have 2 slides with ribbons on it and do the calretinine staining. That should be enough. You are now substantiating a diagnosis by another negative finding. The first negative finding you have confirmed by elaborate and intensive systematic approach. So to substantiate your this first negative finding by another negative finding, you don't need to be that intense in your approach. I think having 2 slides with ribbons, and calibrine staining should be enough.
Right. Thank you. Thank you. There is another important question, Dr. Joshi, by one of our viewers, is that it is about gross examination.
Yeah.
So do you have any specific technique for macroscopic examination of the resection specimen? Do you advise transverse sections? How many sections? At what distance from one another?
Okay.
Yeah.
I recommend transverse sections.
Okay.
And I recommend, let me maybe go to the diagram. Well, I don't need to do that. But you take one horizontal section for every 2 centimeters of the resection specimen. So you need multiple sections. And at one particular level, when you take a horizontal section, at one particular level, you may need to take 2 or more sections in the transition zone and in the normal ganglionic zone, because these zones are fairly wide. The narrow zone is narrow. The transitional zone is wider than the narrow segment. So you may need to take more than one section at a particular horizontal section at one particular level. And the same thing applies to the dilated segment. That's the way I would recommend.
Right. Actually, I think there was another question on the same line. So you probably have already answered it, that how many sections should be optimally procured from the dilated, transitional, and the narrow zones? I think you have answered that.
Yeah. That is, it will depend on the length, and every 2 centimeters would be. That is a lot of sections, but I mean, you have to process. Well, it is not so important, but from transition zone, the diagnosis of transition zone to dilated zone, the normal ganglionic zone, all these should be clearly defined in your surgical specimen and clearly reported.
Right. And another question from one of our colleagues is that if you found yourself at a place where you do not have immunostains, how would you make a diagnosis?
Well, when we did not have, since I have been in practice, which is long time ago, 45 years ago, acetylcholinesterase stain has been available. But when I really started to practice even before that, acetylcholinesterase stain was not available, and we made the diagnosis on the basis of absence of ganglion cells alone, and that was considered as the gold standard. But in that era, the patients were older infants or children. We received a full thickness biopsy, so there were more plexuses to look at, more neural elements to look at. The ganglion cells were more numerous, were more mature in these older infants and children. So the diagnosis could be made on the basis of a single negative finding without any ancillary stain. Besides that, the clinical picture also was characteristic. The barium, the findings on barium enema, the manometry were all well established, because these were well-established cases of Hirschsprung disease in older infants and children. The situation is different now. Now the patient the diagnosis is suspected in the neonatal period and is made in the neonatal period in over 80, 85%, 90% of the cases in Western countries, and probably even in developing countries in major medical centers. But if you don't have acetylcholinesterase stain available, I have said that you send it to a referral lab. Of course, there are situations where the clinical, you have gone through the submucosal biopsy in a systematic manner as I recommended, proper site, proper orientation, 40 to 60 sections, examination of each section carefully for absence of prominent nerves and absence of ganglion cells. If you have that, and if you don't have an immunostain, I would, in your situation, because you don't have an immunostain available, I would go ahead with the diagnosis of Hirschsprung disease. But I will do that with some reservation, even with some reservation, and I will try to establish some contact with a referral laboratory. That is now possible in developing countries. In most developing countries, there will be regional referral labs which will do the immunostains. I would recommend that. I will recommend to make a maximum effort to do that. Thank you.
Thank you again, Dr. Joshi. So there is another question. What about if we identify intrinsic nerve fibers without ganglion cells by calretinine? Would you recommend to repeat the biopsy then?
Intrinsic
nerve fibers without ganglion cells on calretinine.
On calretinine, I don't think you go for recognition of ganglion cells. You just go for looking for the granular stain and the stain of the fibers. You don't go for recognition of ganglion cells on a calretinine stain. If you see granular staining or some linear staining, that should be enough to rule out Hirschsprung disease.
There is another question, Dr. Joshi, about the prevalence. So is this condition more prevalent in people who have Asian descent as ancestors?
Well, I don't know about the statistics from Western countries, the Asian Americans living in the United States, for example. But in Asia, there is statistics, there are figures available which tell us that the incidence is as high as 1.4 per 5,000 live births as compared with one case of Hirschsprung disease per 5,000 live births in Western countries. So whether that translates into increased incidence of Hirschsprung disease in Asian Americans or Asian Westerners is something that needs to be looked at, but I'm not aware of any particular publication or any having seen any particular case in my experience.
Right.
But that's an interesting question. Yes.
Right. No, thank you. Let me see if there are more questions. But yeah, I mean, thank you, Dr. Joshi. I think we have come to the end of the Q&A session, and you would be happy to know, Dr. Joshi, that we had lots of viewers, over a couple of hundred viewers who joined on Facebook and YouTube from many countries. And I could see that we had viewers as far away as Myanmar, Kenya, Peru. Then we had people who joined from Libya, Tanzania, India, Nigeria, Mexico, Egypt, just to name a few. This has been and they're very thankful for your comprehensive talk on a very important topic. And we are also thankful for giving this talk to our viewers, Dr. Joshi. And to our viewers, if you like our lectures, please don't forget to subscribe to our YouTube channel, that is Pathcast. And also you can follow our Facebook page, that is Pathcast. And we have a website, that is pathologicast.com, where all the lectures are organized by subspecialty. And our next lecture is coming up. So that would be on October 18th. And we would be switching to neuropathology, in which our update on 2021 WHO classification on CNS tumors will continue. And this would be the 5th lecture on the update on WHO classification. And the topic will be mesenchymal non-meningothelial tumors. And our speaker, as before, will be Dr. Fausto Rodriguez from UCLA. And hope to see you then. This is again on October 18th and 9 a.m.
Hirschsprung disease is also neuropathology.
Right. You're right.
In a way.
That's true.
Yeah.
That's true. And thank you all again. And special thanks to Dr. Joshi for doing this for all of us today. Thanks so much, Dr. Joshi.
Thank you. Thank you. We'll see you.